Now that the biochemistry is fresh, let's tackle the million-dollar question. Does an MTHFR variant actually translate into clinical disease? 1. Evidence grading framework. We'll grade each claimed association using a simple traffic light. Green, strong, reproducible evidence. Guidelines act on it. Yellow, mixed or population-limited evidence. Prudent awareness. Red, largely refuted or no actionable link. Move on. Ready? Let's hit the big-ticket items. 2. Neural tube defects. Green. Folate deficiency indisputably raises neural tube defect risk. Meta-analyses show mothers homozygous 677TT have about 1.6-fold higher NTD risk when folate intake is low. Key nuance: folic acid fortification and 400 microgram supplementation erase that excess risk. That's why every guideline from CDC to ACOG keeps folic acid universal. Bottom line, advise folic acid or equivalent methylfolate to all childbearing patients. Genotype doesn't change that mandate. 3. Homocysteine and cardiovascular disease. Yellow. Yes, TT tends to push fasting homocysteine 2 to 3 micromoles per liter higher. Observational cohorts once tied homocysteine to MI and stroke, but large randomized trials, HOPE-2, NORVIT, showed that lowering homocysteine with folic acid, or B12, did not cut myocardial infarction rates, though a Chinese trial did see fewer strokes in a folate-deficient region. So we label CV risk yellow. Acknowledge it, but treating lipids, pressure, smoking dwarfs any gene effect. I still treat homocysteine greater than 15 micromoles per liter with B-complex, low cost, minimal downside. 4. Venous thromboembolism and thrombophilia panels. Red. Multiple case control mega-analyses. No significant VTE risk from 677TT once folate status is adequate. CAP, ISTH, and ACMG all say, drop MTHFR from thrombophilia workups. Ordering it creates anxiety and cost with zero management change. Put that lab in the graveyard with routine CKMBs. 5. Recurrent pregnancy loss and obstetric complications. Red, yellow. Early 2000 studies were conflicted. Modern prospective data show no consistent link between common MTHFR variants and first trimester loss, preeclampsia, or placental abruption. ACOG do not test. I tag RPL as red to yellow. Focus on antiphospholipid syndrome, uterine anatomy, chromosomal factors, not MTHFR. 6. Psychiatric disorders, yellow. Meta-analyses see a modest association between 677TT and depression. Effect size is small, odds ratio is approximately 1.2 and heterogeneous. However, treatment data matter. 2 RCTs show 15 milligrams L-methylfolate augments SSRI response, especially in TT carriers with high homocysteine. Hence, psychiatry guidelines place L-methylfolate as an evidence-based third-line adjunct. That bumps psych into the cautious yellow column. Test or empirically supplement when depression is refractory. 7. Cancer and other claims. Mostly red. Cancer data are awash. Some studies hint TT protects against colorectal CA in high folate settings. Others suggest slight risk for gastric CA in low folate regions. Net clinical guidance, unchanged screening, unchanged counseling. As for autism, fibromyalgia, chronic fatigue, vaccine injury myths, evidence is either weak or non-existent. Park them in red until better data arrive. 8. Quick myths, debunk. Myth, MTHFR means you can't detox toxins. Fact, liver phase 2 pathways unaffected, no data. Myth, folic acid is toxic if you're TT. Fact, proven to prevent NTDs even in TT. Unmetabolized folic acid theory, lacks clinical harm data. Myth, you need anticoagulation if you're TT. Fact, not recommended, risk negligible. 9. Practice Pearl countdown. 5. Treat nutrition, not just genotype. 4. Homocysteine greater than 15. B complex first, gene second. 3. Drop MTHFR from thrombophilia panels. 2. Pregnancy, folic acid for all, extra if high risk. 1. Psych question, augment with L-methylfolate if evidence lines up. Headline, MTHFR matters in context, not in isolation. Coming up, segment 4, testing decisions. We'll translate this evidence into a yes or no flowchart you can screenshot for your EMR. Click ahead and let's turn data into decisions.